People know you as a prostate cancer patient and as a highly active prostate cancer advocate. What else should we know about you?
Retired Navy, 27 years. Permanently retired in 1995. Ever since my prostate cancer returned in 1996, I've become obsessed with prostate cancer. And I spend most of my time either researching and studying prostate cancer or on my laptop computer 8 to 10 hours every day, because I just have to learn more and more. And first of all, I tried to learn for myself because of my recurring cancer. And then people started realizing that I was learning stuff, so they're asking me questions. And then that worried me, because now I'm going to be telling them what they should be talking to their doctor about. So that's where the obsession started. I started learning more and more, and the more I learned, the more I wanted to learn, and you never learn enough.
What do you see are the critical things men should know or ask their doctor about today when considering whether to get tested for prostate cancer?
Till they find something better, PSA and digital rectal exam is the way to go. It's the least expensive. It's the easiest to do right now. There are other testing that's going on right now where other things are able to discover whether it looks like you've got cancer developing. But until we have something that is as least expensive as we have right now, that is approved by Medicare, and I think PSA and DRE still does its job. I really think that people need both the PSA and the DRE. One complements the other, because there are a lot of people that have very low PSA, but they still have cancer developing. And that DRE was so easy to do anyway. And discovering a nodule or a hardness, that finds out whether or not a person's got something they better be concerned about. What does bother me, and you're aware of that because I've made comments about that before, is I don't believe that there is such a thing as too much. I think we need PSA testing. We have to find out whether or not a person's got prostate cancer. We don't have to necessarily have to treat the prostate cancer. I think my personal opinion is that the onus is on the urologists, because they're usually the first one to diagnose the prostate cancer. The onus is on them to explain all the options they have, and if they have, if their biopsy tissue came out with only 1 or 2 tissue samples with maybe 5%, 10% of cancer on them, they should be telling them about active surveillance, because there's really no reason the man has to be treated right away. And some guys could probably go on for years and years and not have to go through the side effects that come with any other treatment. Whether you have radiology, whether you have surgery, you're going to have side effects that you have to deal with. Some people deal with them rapidly. Other people have to go for months and months, and some people have to go a few years, especially with incontinence problems and impotence. And so over-treatment, yeah, I believe that there is over-treatment. But the statistics they get for their over-treatment bothers me too, because I think that they check anybody that's been treated with they could be active surveillance, but they've been treated. They count all of those as being over-treated, where a lot of those people, I've got cancer, I want it out. And so they make the choice that they want it out. I don't call that over-treatment. That's their choice. It's not over-treatment. I call over-treatment when the physicians pressure them to have either radiation or have surgery. Now, you got to get it out. That's over-treatment.
Do you think the timing of the conversation between a man and his doctor regarding what happens if you're diagnosed with prostate cancer is significant? Some believe if this conversation takes place prior to PSA testing, biopsy, and diagnosis, the outcome is different. How do you feel about this?
I agree that family physicians should be the first line to start talking to them about what this is all about. Why do you have a PSA check? Why do you have a digital rectal exam? And then explain to them what it's supposed to find out. Is it supposed to be maybe if you're having urinary problems, all it is a large prostate. And you don't necessarily have to worry about prostate cancer with something like that, but they should explain to them that the PSA is simply to find out if something's going on. It should be within a certain range if it's normal. If it's not normal, if it's going a little high, then we have to find out, is it an enlarged prostate that you have? We can find that out by a digital rectal exam. We can treat it if it is benign prostate hyperplasia, and we can treat it to find out if reducing the size of the prostate gland is going to bring the PSA back down. But they should also explain that if we do find that looks like you might have cancer, then we're going to do a biopsy. And then if the biopsy determines that you do have cancer, it will tell us, though, what the level of your cancer is, and you very well may not have to have treatment. I think they should explain those things. Or they should say that if it does show that it's more advanced to a certain level, well, then you have several options that you can go through, and maybe they should explain all those options then, like you said, before they even have a biopsy. And so they have a better understanding, maybe go home even and start looking it up themselves to find out what's available to them. Don't want to scare them, though. You have to make them understand that it may not be cancer. That's the big thing. It may not be cancer at all.
Do you think the average family physician is well enough informed to have this conversation with his patients?
They should be training, even the new physicians, the fellows that are coming now up and working for their MDs, that should be part of their training, to understand this men's disease. I'm sure they're talking to some degree with them about breast cancer. I just feel they are. But I don't think they're talking to them about prostate cancer. And that's one of our biggest shortcomings. They're not talking about it enough.
Do you personally recommend that men get a baseline PSA value in their mid-30s to early 40s?
If they have a family history of either breast or prostate cancer, or if they're African American, 35 years of age. That's my thought. And otherwise 40 years of age, not the 50 years of age that they've been using for a long time.
Why do you think we have been so much less successful at getting men to advocate for prostate cancer in the way that women advocate for breast cancer?
I don't think men want people to know they have prostate cancer. I don't think men want people to know that they're having urinary problems. I think that men are afraid before they even know if they have that they have cancer. They've heard it about erectile dysfunction problems. And I think there's part of our problem. But now we can go to the guys that have actually been diagnosed with prostate cancer. Why don't they go out and advocate? Just like the blue ribbon band that we wear from us too. Support, educate, advocate. We call it sea blue now, that's our color. That's the whole idea. You've had cancer, you're dealing with your cancer, maybe you've gotten what you think is cured. Why don't you go out and help tell other men about the fact that they should be getting prostate cancer, go through the prostate PSA test and the DRE. Those are important things. But men, even our support groups. We had over 400 member mailing list. We finally went out to everybody and we said, we want to reduce our mailing list. If you're not coming, if you want to continue being on it, send us cards back. We got 250 cards back. So we have a 250 member. How many show up at our meetings every month? Anywhere from 40 to, it can be up to 100 depending on who's the speaker, what it's about. And of course the most important things that everybody comes to is incontinence and impotence.
You have long been an advocate for 3-drug hormone therapy, or ADT3, for men with advanced disease, but there are still no randomized trial data to support this strategy. Why are you so convinced?
Lupron shuts down the pituitary, LH, Leydig cell, testicular production of testosterone. That's all Lupron does. Antiandrogens, Casodex, flutamide, Nilandrin, all that shuts down is androgen receptors. Adrenal glands are still pumping out androgen, and when the testicular production drops down, the adrenal glands try to pick up some of that, so they pump out more androgen that becomes testosterone that hits 5-AR in the cancer cell nucleus, and when it hits the 5-AR, it converts to dihydrotestosterone, DHT, and now you got something that's about 5 times to 10 times more powerful stimulant to cancer cell growth than you had with just testosterone. So each one serves a different purpose, completely different purpose. So they all have their reasoning to be there. I don't particularly believe that all androgen receptors are necessarily blocked when you have just Lupron, just an LHRH agonist. I don't necessarily believe that every single androgen receptor is blocked. And if any one little androgen receptor is not blocked, even what little testosterone is coming out of the testicles, but for sure any that's coming out of the adrenal glands, if it gets through any androgen receptor that's not working, there you're back to stimulating the cancer again. So each one has a purpose. That's why I'm a strong believer in triple hormonal blockade.
What would you say to men today regarding prostate cancer?
Men, if you're not getting checked, you should be getting checked. Those of you that have already been checked and already been treated, you owe it back to your brothers to be an advocate to push for prostate cancer awareness.